Murthy, who's no stranger to any of us. She's a dynamic chairman ARC and a dear friend from Coimbatore who's got amazing repertoire in both refractive surgery and cataract surgery, and of course other things, glaucoma as well. So she's speaking on a very important topic, which I thought will really add a lot of value to our surgery. And as I said in the beginning, that refractive lens exchange is now, in correct indications, it does give us excellent results, and she'll try to talk about that. Yeah, thanks.
Thank you very much, Gaurav. It's always a prestige to be a part of your course, and the kind of hall being filled up, although it's such in a remote corner, makes me believe that it draws. And I'm going to use this opportunity on the podium to invite you all to my course in the afternoon in the same hall. Those of you interested in refractive surgery will enjoy it. So on to my topic, clear lens extraction now. Is that an option? All along, we did think that clear lens extraction is not an option, and we go double up on ourselves to tell these patients who are erroneously advised by some non-refractive surgeons that clear lens extraction is a bailout for them. But today, I am talking something a little different. So refractive lens exchange, or clear lens exchange as you would call it, is a purpose of treatment not to treat the pathology of the eye, but because this patient wants improved visual acuity, because he believes that the eye ophthalmic surgeons are poised to do A-grade cataract surgery nowadays, and why should he not get visual independence in their late 40s when they could have, why wait till 60 when they get a cataract? So now why this mind change has come in our patient population, where mild hyperope with a presbyopia comes to you and asks for a solution to get rid of glasses. And then there is the other segment of high myopes who are so distressed that they can't do LASIK, and they keep coming back to you. And then you are in a quandary, do you touch these eyes? I wouldn't touch a high myope at the age of 18 or 20 or 30, but I am talking in the presbyopic age group. The why is it? Because there is an improvement in the technology as we understand now. The intraocular lens designs are absolutely amazing. The kind of fluidics of the phaco machines which are there are so brilliant. And you know that the cataracts are going to be absolutely soft. You could just use a flip mode and carousel it out. So why not? Today we have ways of correcting the toricity. Today we have a femtocataract platform to treat these, especially this group of eyes, and you can address even small magnitudes of astigmatism with just an arcuate insection. And why would you deny these patients clear lens exchange? So I'm going to discuss these two relevant groups. One, a low ametrope and a presbyope. Now, your challenge is, this man wants perfect vision for distance and near. He has a small hyperopic error and he just wants to be free. You have to be very choosy that you choose the right kind of lens. You have to counsel him, understand what he needs. Does he need is great in a distant vision at all times? Does he need trifocality? Does he, and you would not do the two eyes in a very short interval, maybe a week's interval. Check the first eye and do a slow strategy, then choose the other eye, whether you would add a little more myopia, a micro monovision you would do, or would you give him an extended depth of focus? Would you do an extended depth of focus in both eyes? Largely, when you do mix and match, you prefer to use the same material, but sometimes in these eyes you may have to differ based on the need of the patient. And again, a patient with a high refractive error, not corrected by ICL because AC depth is less or too much for a laser vision correction, you have to explain to him there is a loss of accommodation which he is going to find, and you also need to tell him that the architecture of these eyes, whether they are too small or too large, is a huge challenge, and there are challenges in that. So let me discuss case one. Now this is a low hyperope. He needs intermediate vision correction. He needs distant near vision correction. But if you have access to eye trace, you understand why this person has come to you. Not all of these presbyopes want a clear lens exchange, but those of them who have a dysfunctional lens syndrome, they do have some amount of loss of contrast or scattering of light, and they are those patients who want a better visual acuity when they are driving. And if you put them on eye trace, you realize that the dysfunctional lens index is less than 5, and that is why he has knocked on your door. And these are those ideal patients for whom you could consider doing a clear lens exchange. If you look at the point spread function, you look at the higher order aberrations, you are there. And you need to be particular that you use an optical biometry if it is possible, whichever brand you use, because we need to do the very best for this group set of patients. If you have access to an IOL Master 700, you understand that there's an advantage of the Swift-Sort OCT and the B-scan combined, wherein you're going to get all the parameters on the anterior cornea, the posterior cornea, and the corneal thickness and the lens thickness. You can never go wrong on the fixation check. You have this telecentric keratometry, and all put together, probably that would be the most ideal platform. And you should use the 4th generation formula and more. Although you would say that you have used the earlier generation formula and you're doing well with your results, but there is absolutely no clear compromise in this clear exchange group. So you need a generation formula where they have lot more variables which are incorporated, as is mentioned there, because the concept is we need to know the effective lens position, and the more minutely these higher generation formulas, later generation formulas go about adding so many variables, like even a lens factor, which is a distance between the iris plane and the principal plane of the lens. So this kind of exactitude in knowing where the lens sits in the bag becomes more important. If you're on the Barrett suit, you have the Barrett Universal 2 formula, which is a mathematical formula, a thick lens formula. But look at it, besides all the other things, it also measures the principal plane of the particular lens. That depends on the geometry of the lens, whether it's a biconvex or a plano-convex or a meniscus lens. It will tell you where the lens will sit in the capsular bag. If it is a Barrett toric, it is not only going to tell you whether it's against the rule or with the rule, but it is also going to tell you the exact measure of the posterior corneal astigmatism. And that brings greater exactitude when you're going to do a toric correction. And if you have the Barrett True K, then it understands, tells you that there is already a difference in the relationship of the anterior and the posterior cornea in these eyes. So it uses the mathematical formula, the double K solution, and it gives you a True K formula. So again, if it is an in excess, you know the Barrett RK formula can be used. Now let us understand, in 70% of the situations there's no challenge. It is only in 30% of the situations wherein these patients could have a standard deviation which is way off. Then you find they have dry eye, and you treat the dry eye, you realize the values in 2 modalities are all same, and after that you're done. You could take up these eyes. Again, if it is a post-RKI or a keratoconus eye or a PMD eye, you can't do a topography. You need to have a machine which has tomography incorporated. You need to understand the posterior corneal astigmatism, and then if you're doing toric, you need to use the right kind of a calculator and use the best formula. Now this was a case of LRCS with trifocal, and he had a small amount of astigmatism in both eyes. And if you have access to the femtocataract platform, you can see that all you have is literally a free floating rhexis, a very gentle hydro, some amount of pneumodissection is done. All you're doing is just separating those nuclear fragments. Imagine there's no stress to the capsular bag, hardly any manipulation, there's no flutter of the iris, the anterior chamber is so stable, and all that you're doing is just picking up these fragments, literally like as if you're cutting on a cheesecake, and the way these comes folding up on themselves. And this is the kind of precision is what this clear exchange patient is going to need. I'm not saying all of us should have a femtocataract, but I'm just trying to show you how you are able to do the surgery with such absolute ease. Believe me, it's barely edited the case. That's how the case does. It is not at all dependent on the surgical skill, and you have to just center the first and the third Purkinje images, ensure it's well centered in the bag, and just firm up the eye. And once you have firmed up the eye, you could go ahead and do your arcuate incision. You could even do your arcuate incision even before you start the case, while the eye is firm and the surgery is done. And look, this is the kind of result this patient will have, one after the other and in all situations, and they're going to be happy. The case 2 is a high myo. Now this guy has a -14 and odd cylinder, and again there's nothing for him to do a laser vision correction or an ICL. You have to evaluate the posterior segment carefully. You have to tell him a guarded visual prognosis. Chances of RD is there, but he had a PVD, which was again played to your advantage. And you need to do a B scan, look at the posterior staphyloma. If it's a posterior staphyloma, you would rather do an optical biometry. You want the refractive axial length. you would look at the latest formula, a Barrett Universal H Hill RBF or a Van Cox modification. You have to be critical as to what you choose. Now, in a long eye, what you need to understand, you're using a low-powered IOL. So low-powered IOL, the refractive surprise is not going to be much, and the ELP will not be impacted with the visual outcome, and you get done. But in the surgery, what are the challenges? What you need to understand is it's a deep AC, difficulty in manipulating your instruments. You might end up thinking the eye looks big, so you think it's a small rexis, end up with a larger rexis. You would have a myopic shift. You don't want that. You would do a good amount of hydrodelamination, which makes it easier to remove the soft cataract. You would not remove the instrument because the iris can go and get stuck on the lens surface. You could have a reverse pupillary block. Then you have to tap the iris up from the anterior lens surface. You have to always ensure that the infusion is on or viscoelastic is injected so that there is no pressure difference between the anterior and the posterior chamber. And most importantly, you should ensure that you remove the viscoelastic. Steroid responder has to be kept in mind. You avoid anterior lens polishing if it is a toric IOL. And also, if it is a very large eye, you may want to use a CTR if you think there could be a toric IOL rotation because it's a very large capsular bag. These are the things which you have to consider. The other challenge in a high myopic eye, this a high-powered small eye, is that it is a different kind of a scenario, high-powered IOLs. So even a small mistake in your refractive calculation, there'll be a big refractive change. And again, another challenge in a very small eye is that the anterior chamber could be very small, the axial length could be small, vice versa. It will not be an ideal situation. So you need to use the best formulas. You would have to use customized IOLs if it is a very large IOL power. The challenge is you could have increased spherical aberrations in these eyes. Then you might even consider putting the bulk of the IOL power in the capsular bag and using a piggyback IOL for sulcus placement and get yourself bailed out of those kind of movements. So these are the things, the pearls which I've told you, you have to consider and reconsider. You have to do a thorough examination right from the ocular surface, the refraction, to the tear film, to all parameters of the tear film, to everything. Is there an early PCO? You would address that. You would prefer an optical biometry. You should look at the raw data. Believe me, do not let your technician do that. Is there an asymmetry in these eyes? Is there an amblyopia in these eyes? Should you have explained something more? Is there a difference in the axial length? Should you calculate again? You need to treat the astigmatism. Finally, you should plan whether you would give a high ad in one eye, low ad in one eye. Would you do an extended depth of focus? Would you give a trifocal IOL? So what I would like to tell you is choose the right patient, a very driven patient. Explain all the conditions to him. Do a perfect surgery, but with those selective eyes. And when the patient is closer to a cataract surgery but has just a dysfunctional lens syndrome, I think I would choose these eyes for a refractive lens exchange because these are the patients who are keen on a refractive cataract surgery. Thank you very much.
Thank you so much, ma'am. Again, very nicely covered, emphatic presentation with a lot of conviction. Thank